Have you seen energy drinks cause significantly abnormal rhythms in young people?
Their heart rate variability changes because the heart rate is not changing too much. So to answer the question is yes.
Welcome to Next Phase Human podcast. This is a space where we talk about all things related to health. And health is not defined by set tracks of conventional medicine or wellness medicine or what you do in your day to day life. I do believe health is a compendium of all these things. And plenty of times when you're in doctor's offices, of course, there's a limit to that time, and there are questions that are left unanswered on different topics. Those topics may be related to health, may be related to procedures you may or may not need, and may be related to some of the day to day questions, what you can do about prevention. So, this is a space to have all those conversations with the goal that as we age, a number does not define our limits and our genes don't become our destiny. Unlocking the next phase of health, this is the next phase human. I'm your host, Rasham Sandhu, and today I have with me is Dr. Gurjit Singh, a renowned electrophysiologist, former director of electrophysiology lab at Henry Ford, currently chief medical officer of California Cardiovascular Institute, and medical director of AFib and electrophysiology at Dignity Health, Bakersfield, and Adventist Health, Bakersfield, California. Welcome, Dr. Singh.
Thank you, Dr. Sandhu, for having me and giving me this opportunity.
Can you tell us a little bit about yourself, what your background is, and what you do in day to day?
Absolutely. So I'm a cardiac electrophysiologist. It's basically a heart rhythm doctor. I call myself an electrician, so most patients understand that pretty easy. I did all my training, did my medical school in India, and then came to Henry Ford Hospital in Detroit, Michigan, where I did my internal medicine residency for 3 years. Did a year of heart failure transplant training as well. Was not a fellowship, but was an additional training before I joined the cardiology fellowship at Henry Ford. So switched to cardiac electrophysiology, so did my EP fellowship at Henry Ford and stayed on as faculty for almost 8 years at Henry Ford, where I led the EP lab, was the director there, trained cardiology fellows as well as EP fellows, and then medical students. So I had a busy academic practice. I ran the robotic programs, founded the Society for Magnetic Navigation, called SCRN, before moving to Bakersfield. And been here for almost 4.5, 5 years now with Dr. Sandhu. And then we run a busy prior practice where I not only practice cardiac electrophysiology, but all aspects of cardiology and primary medicine as well. So as you rightly said, we got to age well. And today's our topic will be atrial fibrillation. But before I'll answer my claim to fame, I end up discovering when iPhone 12 got launched, the iPhone came with a inbuilt magnets inside the phone, which allowed the phone to be charged on the QI charger.
Mm-hmm.
And we as an electrophysiologist, I implant pacemakers, defibrillators, and these devices have a fail-safe mechanisms inbuilt. For some reasons, if these devices fail, we can put an external magnet to change their capability of what they do. So our hypothesis was that putting an iPhone magnet or iPhone itself on a live defibrillator should not affect those devices because the magnetic field is small. But to our surprise, when we tested in a patient with appropriate approvals and everything, we showed the iPhone 12 actually can turn off a patient's defibrillator. What it does is basically makes the defibrillator stop looking at the intrinsic heart rhythm, and that in turn deactivates a device. So we published this patient data in Heart Rhythm Society, and it became an international sensation because we all knew that magnets are bad for ICDs and pacemaker, but nobody had actually proven in a real human for the first time. So from there on, basically, I started getting calls from Apple and then all the FDAs. So I was on the panel for the FDA with all the device companies to figure out what's the best recommendation. What do we do? We went back and forth. Should the device companies should change their sensors inside, or does Apple should take away the magnets? And the end result was basically the recommendation came in that patients with pacemakers and defibrillators should stay away from strong magnetic fields at least 6 inches away. So keep your phones or anything which has magnets 6 inches away from your device.
So that'll hold true even today for any iPhone or any other phone for that
Correct.
matter.
I tested devices. I took Apple Watches, headsets, and actually checked the magnetic field and everything. Even your regular phone, wherever there are cameras, there is a magnet inside. So we all generate magnetic fields. But again, the bottom line is keep 6 inches away from your body.
So that'll be kind of a safety. Just to kind of explain it to people, that your defibrillator is a device that will shock you internally if there is an abnormal heart rhythm, essentially saving your life. So if turning off therapy can be quite problematic.
Correct. That's absolutely correct. Now, the chances of that happening is very, very low, but there could be one patient sitting somewhere laying down with a phone in his pocket. Especially males have the tendency to put the phones in the pocket, and you could turn off your defibrillator and you may not get the therapy.
Perfect. Well, that's good to know. And let's start today. We're going to focus primarily on atrial fibrillation. Millions of Americans have it. There is several misconceptions about it. A lot of people may know what AFib is or have a basic idea, but there is a lot of misconceptions and fears, and we'll go through them one by one. So first of all, for our listeners who are not in medicine, can you tell us, for a layperson, how would you explain what atrial fibrillation is?
Yes, so atrial fibrillation, as the name suggests, atria, and they are fibrillating. So before we go into the disease, we need to know what the normal human heart does. So human heart is basically the size of your fist, sitting in the middle of the chest. It's like a car engine. It's pumping blood. It receives blood. It sends the blood to the lungs to get it cleaned. The clean blood comes back to your heart, and it gets pumped out. So the heart has 4 chambers, 2 top and 2 bottom. The top are called the atria. The bottom are called the ventricles. The atriums, they contract first, push the blood down through the valves into the bottom chamber, and then the ventricles will squeeze and push the blood out to the body into the lungs. And a normal human heart, if you hold in your hand, it will not beat on his own. The heart is a muscle. It needs a signal. So me and you are born with a pacemaker given by the higher power. It's called a sinus node, sitting in the right top chamber. That actually creates your heartbeat, 50 beats a minute, 60 beats a minute. So think about it as like a car's battery. It's sending impulses every 60 times a minute. That electricity travels in the top chamber, make the top squeeze, the atrium, and then there is a wire inside the heart called the AV node, atrioventricular node.
So just to clarify, it's a highly conducting
It's a
tissue.
highly conductive tissue. The whole heart is a muscle, but then it's also conducting electricity. And is the only organ in the whole body which is actually moving. Rest, everything is stable and stationary. This is the only moving organ which is squeezing and conducting electricity. So a very highly complex organ. So anyways, the blood goes to the bottom chamber and then comes out to the body. So that's a normal human heart. And when we do an electrocardiogram, we can see the heart's electricity. So the top beats first, then there is a time delay, and the bottom follows. On an EKG, it's called a P wave and a QRS. So when me and you right now in normal rhythm, our heart is beating at 60 beats a minute, so that's normal sinus rhythm. So now we know what normal is. When people or patients go in atrial fibrillation, the top chambers stop listening to that pacemaker and starts fibrillating. It starts beating in a very irregular, chaotic manner. There is no rhyme and reason. A lot of things we do in electrophysiology have some circuits, we can define the wavefront and things like that. During atrial fibrillation, the top chambers are basically squeezing in a very haphazard manner. So the top chamber loses their squeezing capacity, and the rhythm becomes irregular. So the definition of an atrial fibrillation, you have to have a 30-second documentation of an irregular rhythm on an electrocardiogram or a wearable or any kind of recording of the heartbeat. So that is what definition of atrial fibrillation is.
So a lot of these thought process will come, okay, is every irregular rhythm atrial fibrillation? Because people get alerts on their wearables all the time. So would they worry every time they see an irregular flag on a wearable? Is it AFib always, or could there be other things that it could be pointing out?
Correct. Just somebody has an irregular rhythm doesn't mean they have AFib. Again, you have to look at the data, right? If you're doing a 1-minute EKG, you have to show it to somebody. See, all these variables or all these devices, they have what we call a PPG, photoplethysmography. So what these variables like an Apple Watch or a Garmin or all these sensors, they're actually looking at, they send an electrical, a light signal towards your wrist or towards your palm. And then the light intensity changes based on your blood flow. So what these devices are doing, they are actually measuring your from one beat to the second beat. That's all they know. But they don't know where is the beat coming from. If you have an extra heartbeat called a premature atrial contraction called a PAC or a premature ventricular contraction called a PVC, that can fool these devices. So again, as I said above, loss of a normal P wave on an electrocardiogram or a variable and have to show it for 30 seconds consistently, then we call the rhythm as atrial fibrillation. But again, to answer your question, if your watch or your variable tells you that there is some irregularity, it's better to get it checked.
And generally, like the thought process always has been heart disease is a disease of older people. Could young people have AFib too?
Yeah, that notion is changing. Atrial fibrillation, when I was in training, this is what my mentor taught me, that is the wrinkle of the heart. But I can tell you, our average patient now who are coming to our clinics in atrial fibrillation, I'm talking about 30s and 40 years of age. The whole health, and that's why we're doing these podcasts, right? Our people are not aging the way they're supposed to age. So it's all connected. So the disease is manifesting early. Plus also now, because we have all these variables, we're detecting more of these rhythms. Before we didn't have the technology. So there is the two explanations for early detection of these rhythm problems.
So could there be, do you feel AFib? Or do you not have to? You could still have AFib and not know about it?
Absolutely. So almost half the patients who I see on a daily basis feel AFib and half do not, especially if you're a female. They don't feel their AFib. And on the worst, if you're diabetic. As we all know, diabetic patients have changing in their autonomic nervous system. They have nerve injury or neuropathy, so they don't feel their symptoms. So the common symptoms of atrial fibrillation are mostly fast pulse and irregular pulse, some unease in the body. People can get short of breath. They can get tired. Fatigue is a very common symptom for atrial fibrillation. If you are underlying heart disease, your low blood pressure, you can get, almost passing out symptoms. But the most common symptom my patients tell me is that something is not right in my body. That's the most common symptom I see from atrial fibrillation.
So if they feel they're just not feeling right, regardless of age, could be a younger person, could be an older person, this could be one of the things. It may not be the thing, it could be one of the things you will look for.
Absolutely. If you don't have an alternative explanation, it could be atrial fibrillation.
Got it. So I presume, how long have you been practicing now in this
Practicing electrophysiology since 2014.
So you must have seen thousands of AFib patients and treated?
That's what the bread and butter for all the electrophysiologists in this country is.
So tell me a couple stories which really stick out, shocking stories, or what did you find most shocking when you treated a patient like AFib? What sticks out in memory?
So, obviously, we treat a lot of AFib patients. And I'll tell you one more thing. No two AFibs are same in terms of their presentations and in what they have inside. So a lot of patients say, oh, this patient had an ablation done, this had this done, and they did this. So I'll tell everybody, please do not compare your atrial fibrillation to other patients. So again, atrial fibrillation causes a lot of problem. It creates the blood to clot in the heart. So I've seen patients who their first presentation is a massive stroke in a young person. So again, that is a shocking story, right? If somebody would have detected an AFib early on a patient, something could have been done. A lot of AFib. AFib increases the risk of heart failure 5 times. It increases the risk of stroke 5 times. It actually changes your mortality. Patients who have atrial fibrillation, they are on a different trajectory altogether. AFib brings chronic kidney disease, worsened kidney impairment. The worst now, or the new data coming out, atrial fibrillation is linked to dementia. And there is some data showing that early treatment of atrial fibrillation with ablation does help or prevent some dementia. I'll tell you a recent story. A patient came to me, atrial fibrillation diagnosed almost 15 years ago. And I can tell you, most people agree that the longer you stay in AFib, now we're talking about 2 different kinds of AFib. The AFib is one is called paroxysmal AFib. When the AFib episode comes and goes away on his own, or we do something, that's called paroxysmal atrial fibrillation. If you stay in the rhythm continuously for more than 7 days, we call it persistent AFib. And these definitions help us figuring out the underlying pathophysiology or what is happening inside the heart at a molecular level or at a structural level. So the shocking story, this patient for 15 years of AFib has heart failure. Uh, Everybody abandoned his rhythm, and they said he came to me with symptoms of fatigue, tiredness. His heart pumping was somewhat weak, and we discussed that it's too late now. He's a relatively young person, and usually at that stage, if we feel that somebody's having symptoms from AFib, we usually give them a strategy called an AV node ablation, pace and ablate. Patient said no. He said, "Can you do something about it?" Long story short, I started treating his AFib. We did procedures, and we also have the capability now of doing what we call an epicardial ablation. So when I do my procedures, I go from inside the heart. I work with some surgeons who
Can you explain it for the listeners what AFib ablation is before we...
Correct. Ablation is a therapy where we go inside the heart, not by opening the chest. We go through the groin to the femoral veins, and we go inside the heart with tiny tubes called catheters. Those catheters help us map the atria electricity, and based on what the scientific literature has shown, pulmonary veins, so all the blood coming back from your lungs. You have a right lung and a left lung. Both of these lungs have these tubes called pulmonary veins. These tubes are draining blood into your left upper chamber. Right before they enter the heart, the lining of these tubes is where 90% of the AFibs actually get triggered. So this is called pulmonary vein trigger. Back in 1999, Michel Hassaguet from Bordeaux, he's the one who actually discovered. They took patients with atrial fibrillation, they put catheters, mapping catheters, and they waited for AFib to start. And they figured out 90% of the AFib started in one of those 4 tubes. So the ablation in a layman explanation is we are going to go inside your heart, and I'm going to isolate, create electrical scar in your heart around the openings of those 4 tubes. You can do by burning, called the radiofrequency. You can do by freezing, called a cryoenergy. And these days, the new kid on the block is called electroporation or pulse field ablation. So once we isolate those 4 tubes, the AFib can start in those pulmonary veins, but it will not enter your main heart, and you will remain in normal rhythm. So that's what an ablation is. So what we do is called endocardial. We're going from inside the heart. On that patient, we did also what we call an epicardial. Heart is a thick structure. The atrial tissue, the wall is at least 4 to 6 millimeter, depending on which way you look at it. And then you can also burn from the outside. So believe me or not, and that patient has been 6 months after treatment. He's in normal rhythm after 15 years of AFib. Heart failure has improved. His life has changed. So again, I see those shocking stories pretty much every other day in the clinic where we have done something for AFib.
And is it correct to say, like, in the past, so you defined atrial fibrillation as paroxysmal, which is the early pathway, and then you defined it as persistent, which is well established, has been there for a long time.
Right.
And those are harder to treat. So is it a fair statement several years ago that was really not considered treatable, that you will just manage it? You're not going to try to get the person out of it?
Absolutely. So there were a couple of trials which were done in olden times. We call now them olden times. One of the famous one is called the AFib trial, where basically they took patients with AFib, persistent and paroxysmal, mostly paroxysmal. Half the group was treated with the regular medications, control the rate, keep the blood thinners on, and see what happens. The other one had ablation done. And that time, the trial with those technologies showed it doesn't matter you do rate control versus rhythm control. You keep them in AFib or you don't keep them in AFib, patient have the same outcomes. Things have changed. 20 years later now with the new technology, with the aggressiveness and with more early diagnosis, I believe the trajectory after an AFib ablation for most patients is changing in a positive way. And then there is something called long-standing persistent. When somebody's in AFib for more than 1 year, we call them a long-standing. And the reason we define these things is, again, AFib is not just one particular disease. A lot of things I do as an electrophysiologist, people are born with extra wires called WPW, AVNRTs. We go in the heart, actually find the little tiny wire and burn it. Those are curable rhythms. AFib is a final representation of many different things happening to your heart, and the final disease shows up as an AFib on an EKG. But behind the AFib, we're talking about the triggers we talked about. So trigger is one thing, but the second component of the atrial fibrillation world is the substrate. What is happening at the structural level in the atrium? What is causing fibrosis? The more scarring, we call it scar. When I go inside the heart, when I make a 3D map, I can see which part of the heart has scarring and not. So the more scarring, you have a bad substrate, the longer you're going to stay in AFib or you become persistent AFib. The third thing we talk about is the ionic level. At the cellular level, what is changing? and the fourth is your genetic predisposition, and the fifth is your age. So all these things actually combine together to bring out, paroxysmal versus persistent atrial fibrillation.
So when you talked about substrate, just to clarify, we are talking about modifiable risk factors that people can fix in their day-to-day life. What would those be?
So again, as everything in medicine, there is something we talk about risk factors, right, or the comorbidities for a patient. So there are modifiable risk factors, just like for atrial fibrillation, and a non-modifiable. So what are non-modifiable risk factors? Number one is your age. You cannot change your age. You're going to grow old, right? Number two is your genetics. We know that non-Hispanic whites have the highest incidence of AFib. Then comes the Hispanics. Actually, having an African American descent, or the Black Americans, have lower AFib. And there is data that because the atrials are smaller, they actually have less AFib compared to whites. And then obviously Asian. So there is some genetic predisposition. European whites have the highest risk of gene. And there are so many, we call this single nucleotide polymorphism. Now there is a big studies going on. So there are some genes which predict that you are going to have a higher risk of atrial fibrillation. So again, those are non-modifiable. We cannot change them. What is modifiable is your standard, your hypertension, your diabetes, obstructive sleep apnea, smoking, weight, obesity, exercise. All those are what we call the modifiable risk factors. All these things work, and diabetes, all these things work together in one form of fashion to create the right milieu or the substrate to bring out the AFib. And then, as I said, the AFib, usually there's a trigger for AFib, and then there is something to maintain the AFib. So there are two separate things in different patients, or there could be two same things in the same patients. A lot of patients start the AFib as what we call paroxysmal. AFib starts, goes away. There are some patients from day one, they become what we call persistent AFib. The moment they go in AFib, they stay in AFib. So again, there is something going different from those patients.
Okay. So just to clarify, all these modifiable risk factors or non-modifiable affect the top chambers in a way that creates scarring in an erratic fashion to create irritability and spread it to suppress your normal rhythm and create a regular rhythm.
Absolutely.
Correct.
And then on top of all this, what actually runs the main thing behind all this is actually your neurosystem, the autonomic nervous system, and the brain. Remember, mind over the heart always, right? So the brain is doing something to your heart as well. So it's the balance of your sympathetic and your parasympathetic. As we all know, humans have two different nervous system, the fight, flight, which is your stress, which is your adrenergic, or the sympathetic nervous system. And then the other one is called the vagus nerve, the 10th nerve, which keeps things calm down. So this balance, whatever changes this balance can bring out AFib or promote AFib. And we know at a cellular level, like if you take a single cell and put two probes in it and you actually look at the electricity, we know that too much vagal tone, too much cholinergic, they actually changes the electrophysiology of those tubes we talked about that can trigger AFib. Too much sympathetic tone, we all know that, high adrenaline levels, right? Caffeine or too much exercise or things which increases the
energy drinks,
or stress, whatever increases your adrenaline, it irritates you through the beta receptors, it's going to irritates the heart and can bring out atrial fibrillation at the top or bad rhythm from the bottom chamber. So again, these two things, the moment the balance changes, we are predisposed to these arrhythmias.
Just for curiosity, have you seen energy drinks cause significantly abnormal rhythms in young people?
I see a lot of young people coming with these energy drinks or, the vaping or drinking too much of coffee, anything which increases just common sense, it is going to bring out some kind of arrhythmias. Usually the resting heart rate is high, their heart rate variability changes because the heart rate is not changing too much. So to answer the question is yes.
Perfect. So we're going to go through, there is a lot of talk about, so there is disease and there is cures that people talk about, whether that be medical or non-medical, and some of those are good recommendations and suggestions, and some of those are just urban legend. So we're going to try to myth bust a little bit here.
Absolutely.
So short answers, let's go through them. So coffee, can it cause AFib?
So again, a lot of the answers I'm going to give you in the world of electrophysiology, cardiology, there is a positive and negative, and all the studies keep fighting with each other. But there is data, somebody did actually trial complete coffee abstinence versus a cup of coffee, and they look for AFib development, and the data shows that, coffee in moderation does not increase the risk of AFib. So I don't stop my patients who have AFib to completely restrict. Yes, if somebody's drinking 4 cups or 10 cups a day, there is a problem. But a cup or two of a regular caffeinated coffee, there is data that it does not increase the risk of atrial fibrillation.
For our listeners, did they clarify the dose in the study? Like 1 cup, 2 cups?
1 cup. There's a trial called the DCAF trial, 200 patients, again, not a big study, but it's a randomized controlled trial. So absolute no coffee versus 1 coffee, and they showed no major change in atrial fibrillation risk.
So for your patients who have either AFib or who have had ablation, what do you tell them typically? Can they drink a cup or 2 of coffee a day?
I tell them, if what's the point of me doing a procedure or something if I cannot make your life easy or don't let you enjoy your life? If you enjoy a cup of 2 of coffee a day, I'd let them allow. And actually, that's what the data show, that anything below 3 cups a day, it's okay.
Okay. And energy drinks, would that be okay for such people?
Stay away from those, because God knows what is there in those energy drinks. First of all, they're high in sugar content, and then who knows what the molecules are. So since these things are not FDA regulated, I tend to usually tell my patients to try to stay away
Even the
from those.
reputable ones, the caffeine content may be just too high for some people.
Absolutely. So it all depends on the caffeine and what the source.
Got it. And there's like magnesium is making big waves these days. How does that affect your AFib? Can it help? Can it hurt? Or doesn't do anything much?
So we all know that magnesium does help, improves our sleep. It does all these the molecules, the magnesium, potassium, sodium, they have to be in a certain level, and heart depends on these molecules or these elements to stay in a normal rhythm. Magnesium per se, when the studies were done, especially in the ICU settings or dedicated magnesium supplements, did not show any change, worse or good, in atrial fibrillation.
Got it. And let's go to something that's ubiquitous in our lives, and people talk about it, stress. How does that correlate to AFib risk?
So again, I mentioned first, right, the parasympathetic and sympathetic. So anything which was going to overdrive your sympathetic system, and obviously the stress, right? So stress, work-related stress, depression, anxiety, all of these have actually, people have studied in population-based studies, ERIC study, the MESA study, people who have these over the normal depression, anxiety, increases your risk of AFib by anywhere from 10% to 30%. In severely depressed patients, almost 30% have atrial fibrillation risk. And the bottom line is, right, whatever increasing your sympathetic tone, you're increasing inflammation. Inflammation causes changes in your cellular structure, more fibrosis. So all these things are connected.
So like we talked about in the premise for the podcast, Next Phase Human, mental health is not separate from your physical health. Any imbalance in your mental health, whether that be depression or anxiety, will upset the balance in your body. So just for our listeners to clarify, sympathetic system is a system that is fight or flight that helps us rev up the body's systems, and parasympathetic system is the rest and digest system, which calms the system down. Correct. In the simplest terms.
Right.
So we talked a little bit about this. Someone comes to your office, they feel palpitations. Is that mostly AFib, or is that mostly something else?
So palpitations means the patient feel that they're feeling extra heartbeats or something is running fast. That's the definition of palpitations, right? But then you have to look into that. So which means we have to do some kind of monitoring to figure out what is their palpitation. Sometimes what they feel is just your regular natural resting heart rate is high, and whatever they're doing is, and that's going faster, and they can call that palpitation. So it's very important for us to actually do these, what we call diagnostic testing, which talks about, start off in the clinic as a 12-lead electrocardiogram where we hook them up those EKGs. If that gives you an answer right there and then you're done. Otherwise, we put them in a monitor called Holter monitors, event monitors from 14 days to 30 days. There is something called a loop recorder monitor. People who complain of palpitations and all other regular tests keeps coming normal, we implant a device. And then obviously now is the age of wearables, the Apple Watch, the Fitbits, and the Garmin. And then there's another called a Cardia app. You can buy this thing and you put your fingers on it, basically doing a single lead EKG. So you need to have some kind of information collected from your body in terms of electrocardiogram to give us the diagnosis, what is causing the palpitations.
How good is Apple Watch for AFib detection?
So the Apple Heart study, almost had 400,000 patients, and they looked at, And these patients never had AFib. So these are patients who have not been diagnosed. And I think 2,000 of these patients were found to have an abnormal rhythm detected by the Apple Watch. This is the first study. And then those patients did the formal testing, with the 12-lead electrocardiogram or monitors. The sensitivity, specificity, or the chances of how good this Apple Watch was almost above 90%. So the Apple Watch actually is pretty good. And to the point that now, you won't believe this, obviously it's designed or is approved to detect atrial fibrillation. But I have few patients who have seen they're having palpitations. They put their watch on. They did the 30-second EKG, and you believe it or not, I have discovered patients with what we call ventricular tachycardia, one of the most deadly rhythm. So I have happened to have few patients who are actually giving us diagnosis. But again, remember, you have to wear it. You have to do the EKG, and then data in, garbage out. If you don't put it right, if the watch is not well tied, you're going to create artifacts. The biggest thing from all these variables is how to differentiate the noise from the real data.
So just to clarify, ventricular tachycardia is a very serious rhythm. You can live with AFib for a long time. With ventricular tachycardia, usually it's an emergency.
Correct. Yeah, that's a total. Anything which is happening to the bottom chambers is taken more seriously. Even AFib is serious, but AFib has the imminent what we call cardiac arrest or risk of death. People do die from AFib. It increases your mortality by twice. But what happens with AFib is either you end up developing a stroke, then you have disability, pneumonia, and so on and so forth, or you develop heart failure. And if you don't manage the heart failure, eventually the pump will fail and you'll die from it.
So just to kind of go into why does AFib cause stroke?
So in the beginning, remember I said the top has to beat in a synchronous fashion. The two top chambers beat together, the bottom follows, at 50, 60 beats a minute. And the heart has to squeeze and push the blood down. So me and you, all humans are born with a tiny chamber, just like you have an appendix in your gut, and we don't know why that is. Same way, you have an appendix in your heart. It's called left atrial appendage. It's a tiny finger-like projection where in a normal rhythm, the blood goes into that chamber, it squeezes and pushes the blood out. When somebody goes in AFib, that chamber or the left atrial appendage, it loses its contractile function. It starts fibrillating. The blood starts pooling inside the appendage. And there are other things going on, but that blood will clot. If the clot breaks, the left atrium is going to send to the left ventricle and through the aorta. It can go anywhere. It can go to your tip of your toe, to your kidneys. Usually, more or less, it goes straight up your carotid artery and goes in your brain and then gets lodged into one of the arteries. And whichever part of the brain doesn't have a blood supply, you call it a stroke. So AFib is the most common reasons for disabling strokes.
So to prevent it, these patients have to be on blood thinners, correct?
Correct. That's the best we have. As said, atrial fibrillation causes stasis. It makes the blood start becoming thick and start pooling. So obviously, the only thing we have to prevent that is to prevent the AFib and then to keep the blood thin by using drugs called anticoagulants.
So we'll tackle more into this management part in a little bit, but I just want to touch up on the drinking. So alcohol is associated with irregular heartbeats or atrial fibrillation. So how big a deal is that? Can just one night of drinking cause AFib?
So alcohol is an important topic. 37 million Americans drink alcohol. That's the data statistics, right? Mm-hmm. With the alcohol, there is a dose. Everything has a dose and response curve, or if you can draw. So alcohol has a linear dose response. The more, as you start increasing the dose of alcohol, the risk of AFib goes up, and other things too. There is, and so for alcohol, just like radiation, there is no clear safety threshold. Any amount of alcohol is bad, right? So there's a pooled analysis cohort of 100,000 patients. They looked at those patients, how much were they drinking? One drink per day, which is 12 grams of ethanol. Just one drink increases the risk of atrial fibrillation by 16%. So again, there is no safe zone. The more you drink, with beer or cider-based alcohol, the dose response is absolutely clear. You increase the number of beers, the AFib risk is going to go up. With red wine and a white wine, the dose response is what we call a J curve. So a little bit of a certain extent, it protects you, but the moment you cross the limit, the risk of AFib goes up. So again, to my patients who drink alcohol or who come with AFib, we usually tell them, please do not drink. And a binge alcohol drinking, let's say you You don't drink on a daily basis, and on a weekend you end up drinking 4 or 5 drinks in a short period of time. Alcohol again is going to make you diuretics, right? So you're losing blood, you're losing fluid, you're increasing your catecholamines, you're increasing again the sympathetic and the parasympathetic comes in, and poor sleep, your heart rate variability goes down, and guess what? You're going to develop atrial fibrillation because that is triggering those pulmonary veins to bring out AFib.
So even one night of heavy drinking can put the right person in AFib. Is that
Absolutely, and you don't have to be diabetic, you don't have to be obese. Certain drink or alcohol, too much alcohol in a short period of time is usually a trigger, very well-known trigger for atrial fibrillation.
So there's a term ascribed to it, holiday heart.
Correct.
That's a real thing.
That's a real thing because you give rest and you're not promoting the surges of sympathetic tone.
So holiday heart mean if you on your holidays you drink a lot, you can have AFib. Correct.
Potentially. I mean, again, as I said, even one drink increases the risk by 16%.
So we talked about risk factors earlier, and we talked about sleep, weight, alcohol, exercise, stress. If you had to rank them, like, okay, I come to your office and I'm like, you know what? I have stress in my life. I do like to drink every so often, a drink or two. My day starts with coffee. So what are the things? Okay, give me top 3 that I must not do if I am at risk or if I have had AFib. Like, you'll tell me, don't ever do these. And the rest, maybe a little bit you can manage.
That's a good question, but remember, it's a patient specific. So when you come to my clinic, I have to assess all your modifiable and non-modifiable risk factors. But let's say you're a little bit overweight. So we know obesity, again, has a dose response. So just let's talk about obesity first. Obesity or overweight, anything above 25 kilogram per meter squared is defined as overweight. Anything above 30 kilogram per meter squared is the definition of obesity, and above 40s is severe obesity. And in the obesity trials, so the people have done trials, and then the American College of Cardiology recommends losing 10%. If you're overweight or obese, losing more than 10% has shown 30% reduction in atrial fibrillation.
So it reduces your risk directly correlating to weight loss.
And again, obesity is again linked to so many things. Remember, everything is connected, right? You lose weight, you're going to have improvement in blood pressure, you sleep better, you changes your sleep apnea risk profile. Again, obesity's adipose tissue is linked to inflammation. And obesity also has a direct link with the heart. Your heart actually is protected. It sits in it's covered by like a balloon-like cover called pericardium. And inside there is adipose tissue. So people who are obese or truncal obesity have a higher epicardial on the surface of the top chamber, higher the adipose tissue.
The fat deposition.
The fat deposition actually promotes inflammation, and that brings out atrial fibrillation as well. So there is some data direct link from obesity to your heart. So when I look at the patient, let's say if we all live in a stressful environment. So again, the mental health needs to be managed first, right? Coffee we already talked about. But if the 2 things I would recommend is your alcohol intake, and number 2 is your sleep apnea, actually. People with AFib, almost half the patients, or more than actually 60% of the patients with AFib have undiagnosed sleep apnea. The number is actually up to 75%. And it's bidirectional. It's both ways. People who have sleep apnea have AFib, and people who have AFib have actually sleep apnea.
So one pulls the other, and then they keep feeding off each other.
So when patients come to me the first time for any young, old, for atrial fibrillation, what I'm doing simultaneously, I'm making them go do a sleep study, home-based or whatever you do, go talk to a sleep doctor and start working. As we all sleep, especially people who sleep on their back, the tongue is supposed to fall backwards. So we all obstruct. So that's called obstructive sleep apnea. So that is one of the most underdiagnosed modifiable risk factor for atrial fibrillation.
Interesting. And exercise. And obviously exercise will cause weight loss, and we'll get into it. But one of the big topics that's been doing the rounds is, of course, the semaglutides, the Ozempic, the Wegovy, the Zepbound, and they help you lose weight. Is there any data that if you use these drugs for the right patients, do they have less AFib? Is there any studies on that?
There is data now. Semaglutides, these are the wonder drugs now. They're changing everything, right? They're designed for weight loss, but we know that they reduce inflammation. They have cardioprotective. Semaglutide, letriglycide have cardioprotective risks, and then there are studies, and there is like a meta-analysis where we combine all the studies together of 26 studies. They show using GLP-1 agonist, semaglutide, reduces the risk of atrial fibrillation by 17%. So there is data getting collected. Again, remember, this is all new. But yes, if patients are having other cardiovascular, patients with heart failure, these drugs are helping. Invariably, it does correlate into helping with the atrial fibrillation too.
So, say someone comes to you, he's moderately overweight, and you tell him lose 30 pounds. Can it fix his AFib?
It can, but the problem is how we're going to do that. Because now, once you're obese, you are in a vicious cycle, right? I mean, these are big patients. I want them to go exercise. Their knees are already hurting. So again, the theme in atrial fibrillation used to be, I think we were putting band-aids, right? I mean, you're giving drugs, you're doing ablations. But now the new goal, even by societies from the Heart Rhythm, from ACC, is AFib prevention is the new, actually, the theme that we need to prevent, nip it at the bud. So again, it's a challenge. Unfortunately, patients in persistent AFib, they're in AFib 24/7, they're obese. Once they exercise, they get short of breath. So you have to start somewhere. So in some patients, unfortunately, we have to go aggressive up front, treat the atrial fibrillation with catheter ablation by taking the chances, of the obesity. But if I can maintain sinus rhythm for at least 6 months in these patients with ablation or whatever, at least I can make them exercise, and do all those things. So it's a continuous cycle.
So exercise is interesting. Of course, exercise is good for body. Now, what is the relationship of exercise with AFib? I read some data that endurance athletes are also likely to get AFib. Is there any truth to that? Like if you're a marathon runner, or a long distance cyclist, which a lot of your patients can be, they're living a healthy life. Are they increasing their risk for AFib?
It's very interesting. You will think these are thin, slim people, patients coming bicycling.
These are not your prototypical
These
AFib
are not,
patients.
and these are the patients who are very well read. I mean, they are good in their supplements, and you name it.
They're doing everything right.
They're doing everything right, but believe me, I see a lot of athletes, especially avid cyclists. We have this nice bike path here. A lot of cyclists are developing atrial fibrillation.
And why is that?
And that's interesting. So exercise, remember I talked about alcohol. Alcohol has a direct dose response. The more you drink, the more AFib. Exercise has what we call a J or a U-shaped curve. So if you exercise less than a certain amount, you have more disease, more AFib, more obesity. And there is a perfect inflection point. So if you start exercising more than, the number is 55 METs per week. MET is like the metabolic equivalent, right? So more than 10 hours of vigorous exercise in a week increases the risk of AFib and other heart rhythm problems. So in endurance athletes, and the reason for that is many, many reasons. So one of the things is when somebody's athletic, remember, when they are doing their activity, the heart is pumping, it's racing fast. To compensate, first thing the heart does is, two things it does. The chambers will dilate. And number two, they develop sinus bradycardia, means their resting heart rate is always in 40s. So that's a compensation. Most of these athletes actually develop their AFib during their sleep. They never develop their AFib during exercise, actually. And that is called the vagal-mediated AFib. Because, again, comes back to the sympathetic, parasympathetic. Athletes have a very high resting vagal tone. And during sleep, that vagus nerve is going to promote those pulmonary veins. It's called the cholinergic mediated. It triggers the AFib. So most athletes actually develop their atrial fibrillation during their sleep, which is even worse. They don't even know that they have AFib. So that's one reason. Number two is what we call the remodeling of the whole heart. Their ventricles thicken. The atriums, there is data now that people who are endurance athletes, marathon runners, their atriums are dilated. And unfortunately, there is data shown that dilatation never reverses. It stays on. Even if you stop, it stays on for years and years. And the bigger the upper chambers, the dilation, the more the risk of all these arrhythmias. And there is data, actually, they took rats. Again, I'm not comparing humans to rats. They have these healthy rats, and they ran them, like vigorous exercise training for 16 weeks. And then they cut the heart and they look at the microscope. 60% of those rats, compared to the controls who did not, have fibrosis, which would be scarring, which you can see through an MRI or under the microscope. So that's the link between too much exercise. So the recommendation is to cut down. So, 240 minutes or something like that, or 2 to 3 hours. If you're doing 10 hours, vigorous in a week, cut it down to 2 to 3 hours.
So vigorous means, like, how do you define vigorous? My exercise tolerance could be very different than yours in terms of heart rate. Like, okay, if I want to tell my patient, at this heart rate for this many hours, because that's how people want to quantify.
Right. And again, it becomes different. Guidelines recommend, they give us a total time frame. Okay, do these amount of mets or, as a 240 minutes.
Mm-hmm.
Again, is there a limit for a particular patient? Okay, you're starting at 40 and you go up to 200. I think that's something.
So exercise which is making you breathless and tired,
That
in
you
the
should not-
simplest
you should
terms,
not do.
like
Correct.
for a prolonged period.
For prolonged
is
period,
that
yeah.
like simplistic?
Like for my cyclist patients who are averaging 100 miles a week, I usually tell them, again, there is no exact limit, but I say at least cut it down by 25%, bring it down to 75 and see what happens.
Mm-hmm.
And now there is data actually for the athletes, and it's very difficult to tell them to not do what they want to like to do. So catheter ablation is becoming a first line for actually athletes. Because think about it, their resting heart rate is slow, which means I have no medication, no heart rhythm medication. We call antiarrhythmics, beta blockers to give it to them. They're already too slow. They tend to get dehydrated. So I don't have much options from a medication standpoint to give to these patients. So ablation usually helps. And a good part of these ablations are we're targeting those pulmonary veins. So the resting heart rate goes up a little bit post-ablation. But a lot of data coming out of early ablation for athletic patients.
And they are at risk for stroke equally too
That
if they
exactly,
have AFib.
right. Stroke risk in atrial fibrillation is defined by there's a risk score we call the CHADS VASC risk score, which is, C stands for congestive heart failure, H is for hypertension, A is for age. Age above 75 gives you 2 points. Other ones, everybody else is giving you 1 point. D is diabetes, S is stroke, or any myocardial infarction, history of peripheral artery disease. So all these risk factors, we do a point-based system. So if you're a male and this CHADS VASC score is above 2 and above, the risk of having a stroke is basically 2 out of 100 chances. If your score is 3 out of 100 chances. For a female, you have to have a CHADS VASC score of 3 and above. So that's the risk scoring used throughout the world in all patients, male or females, athletes or non-athletes, to determine the need for blood thinners called the anticoagulants.
So let's dive into the day-to-day stuff. Okay. Say one of your friends develops AFib now. Okay. Comes to you. As a patient, what are some of the questions that I should be asking my doctor if I am found to have AFib? Where would I start?
So first of all, again, the first thing we assess is, are you symptomatic or not? Like if you have symptoms. And then the other things you're going to ask me, most patients ask me, okay, should I get the ablation early on? And what are my treatment options? Again, we talked about prevention is the goal. We want to prevent further episodes, which we talked about the risk factors. But the question is, should we offer these patients an early ablation, more aggressive ablation?
So even before we go to that, it's new onset. Like there is a procedure called shocking the heart to get people out of
Correct.
AFib. Like, would that be an option for a lot of people to start with?
Right, because the first episode, and let's say you are staying in AFib, right? So which means you're developing early persistent atrial fibrillation. Most patients, we end up doing what we call a cardioversion. Before even we do that, again, my goal is to figure out why did you get into that AFib? Again, stress, did you not sleep well, too much alcohol, sleep apnea, obesity, uncontrolled diabetes, history of myocardial infarction. So we assess for all those, but then in terms of treatment-wise, the step one, usually if you're in a hospital, we end up doing a procedure called the TE cardioversion. We make sure there's no clot in your heart, and then we manually reset your heart by putting paddles on your chest, and we do a procedure called cardioversion. And that will get you back in normal rhythm. The problem is, it's very hard to predict which patient is going to have a recurrence. We know that the older you are, the poor diabetic, the obese you are, and if you already have a heart failure, the risk of developing atrial fibrillation goes up. So the other thing we talk about in atrial fibrillation is what is your pumping chambers doing? Atrial fibrillation can cause heart failure. And now there is a lot of data and impetus towards what we call arrhythmia-mediated cardiomyopathy. We all know that atrial fibrillation causes stroke. But because your heart is not in a regular beat, think about your bottom chamber. Your bottom chamber is sometimes slow, sometimes fast. So this irregularity actually can itself promote what we call LV dysfunction or left ventricular dysfunction or called heart failure. So
the heart becomes weak.
The heart becomes weak. And if you don't treat those AFib, they will behave just like any other heart failure patients.
So if you treat them, the heart function can improve, it can get stronger?
Mostly if it's purely based on tachyarrhythmia or the fast heart rhythm related heart failure, the moment you restore the rhythm normal by cardioversion, by shocking, or by ablation, or by medications, those heart failure usually reverses completely.
So let's go step by step. So I came to you, AFib is diagnosed, or even if I go a step before, I had palpitations, you did a monitor, now I have AFib. Now you offered me cardioversion with transesophageal echocardiogram, which is essentially putting a probe down my mouth under sedation, taking a look at the heart, make sure there is no clot, and then shocking the heart.
Correct.
The rhythm is restored. What would you do next with that patient?
So usually in those patients, because the fact that I had to go in and cardiovert you, which means you're already developing the persistent that your heart wants to sustain AFib. So those patients should be, especially if you in a relatively younger age, and that definition is changing, but we want to be aggressive. So usually the step first is we can give you a medication called an antiarrhythmic to prevent the next episode.
And there are several medicines like that?
There are several medications, and they all work on ion channels, sodium channel blockers, we call class 1 agents. There is potassium channel blockers. There is a beta blocker. So all these drugs are designed so that whatever triggers your AFib, it doesn't let you go in AFib. Okay? So those are the heart rhythm medications. Plus, simultaneously, we're also managing your stroke profile, your risk profile with blood thinners. But then after heart rhythm medications, usually the next step is what we call the catheter ablation. So the question is when to do these procedures, right? If you only had one episode of AFib and you're a younger person, and then I'm able to tell you to modify your risk factors, usually we can wait and watch and keep doing monitoring, by self-monitoring or by event monitoring and things like that. That's usually the right way to go. The other thing in AFib field is called the atrial fibrillation burden. All the trials of AFib to this date, if you look at any randomized trials or whatever we do, the definition of success is 30 seconds or more of AFib after an intervention, which in my opinion, is absolutely wrong.
30-second.
So let's say you do an ablation. I'm doing a trial where I'm going to do half the patients going to go on a drug. The second one is going into ablation. So how do we define success in the AFib world is after an ablation or after a procedure, are you developing episodes of AFib? And the definition to date has been any 30 seconds of atrial fibrillation documented by any monitor is a failure, which my opinion is absolutely wrong. The field is changing. Now the goal of all these interventions is actually reduction of AFib burden. If you had AFib 50% of time before an ablation or an intervention, and now you're down to 1%, in theory that should make sense that is there. So that's where the field is going towards. As if you come to me for the first time, my first job is to assess how much AFib you're having. If you are paroxysmal, means you're come and go, how many episodes you're having in a month. If you're having, like, say, 3 to 6 episodes in a month, it's pretty clear that we should do more for those patients. If you're going to have 1 or 2 in a year, you can argue which way whether you can just manage them medically or, procedures usually not recommended for those patients.
So now that we've gone through the blood thinner part you mentioned, so blood thinners obviously scare people. There is risks to it. It used to be warfarin, which, again, people know it's rat poison, and people talk about it also. Now there are newer drugs like apixaban or rivaroxaban, and we use them, but people are still scared of blood thinners. Now, if I'm a patient and you tell me to take a blood thinner daily, I'm worried about bleeding. If I have an accident or a cut, I can bleed a lot more. What are my options? Do I have any other options to that?
Correct. You're right. So based on the risk factors we talked about, the CHADS VAS score, if you're risk 2 and above for a male and above 3 for a female, you have to be on a blood thinner lifelong. That's the guidelines as of today. Trials are ongoing where patients who can self-monitor their AFib, when they know they're going in AFib, they can start a blood thinner. But again, that's future. But unfortunately...
And that's with Apple Watch?
That's where the Apple Watch or the wearables are coming. But again, those trials are underway. But as of now, as we speak today in 2026, if you have AFib and you have these risk scores, whether or not you had an ablation or not, you're supposed to take the blood thinner lifelong. And we all know that we're all scared about blood thinners. You talk about reasons, you can cut yourself and things like that. So there are alternatives. We call the left atrial appendage management. We talked about 90% of the strokes during atrial fibrillation come from the left atrial appendage.
So that's just to recap, that's a small outpouching in the top
Top
chambers,
chamber.
which does not have a lot of other useful function as far as we know.
As far as we know, but so the surgeons can cut it during a heart surgery. You can put a clip on from the outside, or we as an interventional electrophysiologist or the structural heart specialist, we can actually percutaneously go from the groin, go inside the heart. We can actually plug those chambers. And there are two devices out there which are approved. One is called the Watchman device, and the other one is called an amulet devices. So these are like filters, so to speak. You put them inside those appendages, and then the body is going to form a layer of cardiac tissue to completely occlude those chambers, so that when you go in AFib, the blood doesn't goes into this appendage, and you won't form a clot, and you won't get a stroke. So again, for the right patient at the right time, these devices are available.
So if my doctor suggests to me, okay, you don't want to take blood thinner, we can do Watchman or amulet for you. Let's start there. Is there any particular questions that I should be asking? Is one device better than the other? Is there any data to that? Or is there any particular question I should be asking as a patient from my perspective being responsible about these devices?
So again, to get these devices even approved, remember these are, big procedures. So to be a candidate for left atrial appendage devices, you have to have a CHA2DS2-VASc score of 3 and above. So let's say you are a 45-year-old coming to me for AFib, and you don't have high blood pressure, no diabetes, no stroke, nothing. You do not qualify for this device, just to be very clear and honest.
But you won't qualify for blood thinner in that case.
You also won't qualify for blood thinner depending outside the ablation time frame. Remember, anytime we touch your heart or we do an ablation or a cardioversion, those 4 to 6 weeks after electric shock or an ablation, you are supposed to take a blood thinner. So we're talking about these long-term blood thinners.
Mm-hmm.
Right. So if you have, there is no head-to-head comparison between the Watchman device and an amulet device. The end point is whoever does the procedure, the goal of the left atrial appendage management should be complete occlusion of your chamber. How you do it, that is up to who does it. But we talked about in the past, we're doing these devices, and there was an acceptable leak around the device at the time of implant under 3 millimeter. Now the data has shown that you don't want any leak after 45 days or after the device is completely healed.
Okay. So now we got past the device. You decide the patient needs an ablation. Can you tell our patients what the procedure, or for general people to know what the procedure entails? How big of a deal it is?
So again, catheter ablation is a first-line therapy now. And in the beginning, I remember I said, ablation means to ablate or to change or modify a heart tissue. In the catheter ablation for AFib, we are going inside your left upper chamber, and we're isolating those 4 pulmonary veins, those tubes where
So you go up from the groin?
We go from the groin. So the procedure again entails, right now the procedure can take anywhere from 1 to 2 hours depending on what technology you use. But the procedure is still done under general anesthesia or some form of deep sedation. The access is through your groin. We are going through your femoral vein. So the tubes which are draining the blood, taking blood back from your leg into your heart. So we're going to, under X-ray or under 3D mapping, we pass these tiny wires, electrical wires, and these tubes called catheters. And then the procedure, the most important part of this procedure is what we call transseptal access. To go from your right upper chamber to the left upper chamber, we have to make a tiny hole in the heart. It's called a transseptal access. With a needle, we cross to the left side. And then we take all our equipment into the left upper chamber. We create a 3D map of your heart to see how big the heart is and define what the areas of scarring are. And then once we know where to go and burn or freeze or electroporate, we take this catheter and we can deliver energy. So the bottom line is to deliver energy to that part of the heart where the AFib triggers or starts. How you do it, again, that depends on the operator, but these days, pulse field ablation is becoming pretty much the energy source. And the reason for that is faster, the tools are much more simpler, and the energy is supposed to be cardioselective. When we used to use radio frequency energy for
like
ablation,
heat energy,
we use radio frequency that generates the heat. Not only you are ablating the heart tissue, you're burning the heart tissue, but think about it, the heart is sitting around many other things. There are arteries, there are nerves, there are other tissues, And the heart, the left atrium, sits in front of your food pipe. So the Achilles heel of catheter ablation for atrial fibrillation was actually damaging the esophagus, which can be catastrophic. And we don't know the exact number, but there are chances of development of what we call atrioesophageal fistula. That's the worst case scenario from an ablation procedure.
So you essentially create a hole between the food pipe,
Food
and,
pipe
the heart.
and the heart,
That's a
which
problem.
is pretty much catastrophic, and the mortality is above 90%. Fortunately, touchwood has never happened. Again, that's where the field has moved away from radiofrequency to pulse field. Pulse field ablation is cardioselective. It spares the esophagus to the most part. And that's why the procedure is becoming faster, much more safer now. And once we do the procedure, we take all the catheters out, and then we have groin management. And most patients are going home within 3 hours after the procedure.
So same day discharge.
Same day discharge on pretty much 90% of the patients, unless you have a severe heart failure or you're really old or frail. Then we usually keep them in the hospital, and the recovery is fast. Within 3 to 4 days, we tell you not to drive, not to put too much pressure on your groin, and you're back to your normal lifestyle. But that's what ablation entails.
What are some of the other risks with the procedure?
So again, common risks usually are from the groin access. We are accessing your veins. Even though we are using these days, we call the ultrasound. We know exactly where to put the needle in. But hematoma formation, blood clotting, or injuring the artery is one of the risk factors. During the procedure, the biggest risk is what we call thrombus formation or a clot formation on these devices we are putting in your heart. So when we do your procedure, your blood is absolutely thin. We use a drug called heparin. So you're fully heparinized for the duration of the procedure so that you don't form a blood clot and don't cause a stroke. So stroke is a risk from the procedure. The other risk is we are moving, heart is a beating structure, right? So we are pushing these catheters inside your heart. These catheters can make a hole. The upper chambers are very thin-walled structure compared to the bottom chambers. So we can cause what we call bleeding into the outside the heart, which can cause pericardial tamponade, which can be life-threatening and can cause much problems. So those are the main risk from the procedures are vascular complications, stroke during the procedure, or cardiac tamponade.
Are these like high percentage complications or like uncommon?
These are uncommon. The numbers in high volume centers, if you're doing a lot of procedures and you're using all your checks and balances, the risk is less than 2 to 3% for most of these complications.
And you said you go home the same day for most patients.
Correct.
Any particular downsides after the ablation?
That's a great question. So again, it all depends on at what stage of the AFib you're ablating, right? So when we are doing ablations for paroxysmal AFib or when your AFib is coming and going, usually those ablations are we are ablating the pulmonary veins. We call pulmonary vein triggers. So the ablation is very focused and we're not creating too much scar tissue. The longer you're in AFib, what we call long-standing persistent atrial fibrillation, the atria, the top chambers are very enlarged. Again, the data has never shown there are a lot of trials, like other than ablating the pulmonary vein tissues, no other strategy has ever shown to improve the recurrence of atrial fibrillation. But invariably, we end up ablating more tissue based on the 3D map we have. So the more scar you have, those scar areas can harbor AFib. It can promote AFib. So we end up ablating the back of the heart called the posterior wall isolation. We're ablating a lot of flutters. These patients tend to go into many different fast heart circuits. So the more you ablate, you're creating more scar tissue. And if whatever is ablated is not going to beat. So if you ablate, keep on ablating, if the whole atrium is pretty much scarred and ablated, those atrias do not contract. So you can develop what we call atriomyopathy. They call it stiff heart syndrome. The people can develop heart failure symptoms. They tend to retain more fluid in their lungs, so they start developing heart failure symptoms.
So, but on the flip side, if you stay in AFib, you will still scar the atria.
Correct.
And you can still develop it.
Correct. The famous statement by one of the giants in the EP field is the goat model of AFib. So they put goats into AFib, induced AFib. And the longer these goats, this is like 40 years ago, they stayed in AFib, they tend to have more AFib. So there's a term called AFib begets AFib. So whatever starts the AFib, but once you go in AFib and you stay in, the fact that your heart is in irregular rhythm starts changing your own cells at a cellular level. So you're right. AFib creates scar. Atrial fibrillation can cause the The chambers can get bigger, uh, promotes more scarring. So it's all connected.
So let's go a step further. Someone who's had AFib for a long time or is too old, is there some such a thing as too sick or too old for AFib ablation? Do you offer it to everyone, or?
Again, this is per patient. When they come to my clinic, we have to assess those risk factors, right? Is this patient able to lay flat? Is the patient able to tolerate the sedation? Remember, for me to do the procedure, I don't want you to move. We have to create a map of your heart. So most patients require deep sedation or anesthesia. And if your heart pumping is weak, so people who have severe heart failure, usually those patients will succumb to the anesthesia than the procedure itself. So you have to be in a good shape, a decent shape for me to put you on the table to do the procedure. In terms of age, frailty index comes into, if you are a thin, old, small female, we know that those patients are at high risk of what we call cardiac tamponade. So the risk of perforation becomes an issue. Age is not becoming a bigger impediment to the procedures. I have done ablations on patients who are 85, but they're good, functional 85, have a good, a lifestyle. They want to do more. So yes, the ablation is being available to more older population.
Can pacemakers prevent AFib?
Pacemakers by itself do not prevent AFib, but there is a treatment strategy we use when everything fails or patients who are very frail or especially in extremes of ages. There is a procedure we do what we call AV node ablation. Remember I talked about the wire which connects the top to the bottom? So in those patients, we abandon rhythm control strategy. Means they will stay in AFib forever, but we will make their bottom chambers, they don't race, they don't go slow, they don't go fast. How you achieve is by ablating or burning the AV node. But because you're burning the main wire which connects the top to the bottom chambers cannot beat on its own. So to do that, you have to implant what we call a permanent pacemaker, which is a wire, we have to make an incision and put this device called the pacemaker. So it's called an AV node ablation, pace and ablation strategy. Usually actually is one of the most effective, one of the strategies which has shown to improve the most quality of life in these elderly patients post-ablation, because their heart's never going to race, they never get hospitalized for a racing heart, their heart failure improves actually. And there is something about making the ventricles or the bottom chamber beat at a regular rate that itself actually has been shown to prevent fibrosis and improve heart failure.
So you mentioned a little while ago, I just wanted to touch up on this, that treating AFib or ablation can reduce the risk of dementia. Is that correct?
That's correct. Data is coming in. The AFib itself, remember, it's all inflammation. We have no idea what is changing. This autonomic tone, the sympathetic tone, everything is changing. This vascular stasis, atrial fibrillation causes, stasis of the blood. People are developing most likely microthrombi. You don't have to have a full stroke, but you have silent strokes. And anytime a piece of a brain tissue has a stroke or doesn't work, that area is gone, and that can become dementia. So there is data coming on. Patients who have early on ablation done, actually we're changing the trajectory of developing downstream dementia. Because remember, they're all connected, right? These are the patients who have already the higher age risk. They have diabetes, they have sleep apnea. All these things are promoting the neurological changes.
Great. So AFib ablation, in your mind, is it fair to say it's a first-line strategy for most patients now?
It is becoming first line for most patients now, absolutely. I would, back in the day, we have to show that patient failed. You have to fail one antiarrhythmic drug before you even qualify for an ablation. But now, based on the guidelines, it's a class 1 indications for most paroxysmal atrial fibrillation, early persistent atrial fibrillation, patients with heart failure. There is a trial called CASTLE AF shown that patients with advanced heart failure actually who end up getting atrial fibrillation ablation, they improved heart failure, in fact, time to transplant and time to ventricular assist devices. So there is now randomized data coming showing that ablation, even a sicker population, is actually helping.
Very interesting. So let's look into the future a little bit. Say we're able to look 15 years from now, and you're looking back and this, can't believe we used to do this. What would that be?
Two things which come to my mind is, remember I mentioned prevention.
Mm-hmm.
So like you sitting in front of me right now, and if I have something on you, I put something on you and predict 10 years from now you're going to develop AFib. If we know we can do that, why then we should start working on prevention. So a lot of artificial intelligence, so AI is able to look at your EKG and actually predict your downstream risk of developing myocardial infarction, heart attacks, and AFib. There's a Mayo Clinic study, a couple of other machine language, uh, big data EKGs, millions of EKGs. They have signatures, like they look at the patients who had AFib and who don't have AFib. What are those EKG signatures? So apparently there is AI-based algorithms coming out pretty soon, which will actually predict your risk of developing AFib. So that's one, AI-based. Number two, the AFib ablation world is changing, like the therapy one is changing. But for me, if I have to predict, I think what the field needs to move is patient-specific atrial fibrillation treatment. What that means is, right now we are ablating tissue. We are just basically burning or electroporating a substrate, preventing triggers. But AFib is a complex, nobody's targeting all the things at the same time, right? Whereas the proteinomics, the genomics, your genes, all those things needs to come together. So the ablation, as I do a lot of persistent AFib, so patients come to me who are been in AFib for years and years and years. Is there a way, without me going inside the heart, can I predict from outside how much ablation I need to do? Where should I do an ablation? Or what areas, what nervous system we need to modify? So I think that's where the field is. I predict in 10, 15 years, we will have those tools that this patient needs this ablation at this point in time and this location.
Is there a world in which we don't even create a scar with burning or pulse field?
That's a very interesting question, and I think that point goes back to modulation of your nervous system. There is something with your nervous system because something triggers your AFib. Right now, me and you are in normal rhythm, right? Think about it. Your own sinus node is connected to the billions of your top chamber, right? So one area in your heart is what we call the orchestra, right? He's the master,
The conductor.
the conductor, right? So whatever changes the balance of the conductor from the rest of the tissue, that promotes arrhythmias, right? If we can figure out a way how the conductor maintains its coherence with the rest of the upper chambers, we may have a chance of prevention or preventing arrhythmias without burning anything.
So my 45-year-old friend who is a business executive, a little bit overweight, not crazy, does exercise 2-3 times a week. On the weekend, couple drinks, comes and asks me, hey, my mom had AFib, so I have family history of AFib. What can I do to prevent my risk of AFib?
And that's a great question, right? This 45 years enjoying life, because if I stop having him drink his alcohol, he's going to come to me like, okay, what's the point of living, right? So I think we talked about all those risk factors. So at least if the guy is thinking to prevent AFib, I think that's the winning starting point to begin with. At least he starts thinking about his own health. That's the biggest thing we all need to do in all our patients. Most patients who are coming to us have no clue, what their underlying disease processes is. So that 45-year at least is thinking about it. That's number one. Number two, overweight. Hopefully he start working on that. If he's exercising 2 to 3 times, maybe we can work on getting that weight loss a little bit. Third is, we talked about, mind over the body, right? What are his sleep patterns, which we be coming into the questions of variables, right? What are the tools available to this 45-year-old who can modify his sympathetic and parasympathetic tone? I think that's where I think the key is. He's going to drink. As I said, a drink or two is not going to cause much AFib. But how is this 45-year-old person is aging? That is where actually the key is, where everything else comes to point, right? Your supplements, your GLPs, your HRVs, your exercise. That's what is, I think, the answer to your question should be.
So your GLPs like Ozempic and Wegovy, they reduce weight. And fasting can be used to reduce weight too. Is there any data on fasting and reducing the risk of AFib?
There is no direct data that I was able to pull up, but again, if the fasting reduces your weight, reduces your inflammation, I would assume that there should be some positive impact. If nothing else, at least changes your heart rate variability. Again, balancing those sympathetic parasympathetic system. But I do not have the evidence to directly.
Is there any data on meditation?
There is some data. There is the famous study. It's a very tiny, small study on yoga, which is obviously exercise, which is the mind-based. There is a study on cognitive behavioral therapy. That study did not show any big change in development of atrial fibrillation. There's an ongoing yoga study, it's a randomized trial going on, patients with atrial fibrillation with yoga versus just routine of care. That study is ongoing. But yoga has shown, or the small study has shown, the more meditative you get, you change your heart rate variability, you change your resting heart rate comes down, your blood pressure comes down, you feel better, you change your depression. Remember, depression, anxieties are all linked. So I think the numbers are small, and we don't have a good, like a tool, like one particular tool that we can prescribe to a patient. Okay, do this kind of yoga, and you should benefit. But in theory, it does make sense that if something makes you more meditative and brings your resting heart rate down and makes you more calmer, I would assume that should translate into some kind of arrhythmia modulation.
Thank you. That was very insightful. So, as a part of our sort of conversation, we want to go through at least one tech device every so often to tell our listeners about this. There are many. I mean, tech is coming into health in a big way.
Correct.
So I just saw you wear Whoop.
Yep.
I wear the same. So I just want to kind of go through it. What's your experience from a cardiologist standpoint? When you have Whoop database, what do you see? How useful it is?
I think I should reverse the roles here because you are much better Whoop data, or you have a good analysis of all these variables and things like that. But whatever, these devices are giving some insight. Remember, all these devices are a window to your autonomic nervous system, right? I mean, how do we measure that? One of the things I keep saying is the heart rate variability, and we talk about it.
So can we tell people what heart rate variability is?
Basically is how fast or slow each and every heartbeat will change to your body's external environment, right? So like if you're in fear and flight, your heart rate's supposed to go up. When you're resting, your heart rate is slowing down when you're sleeping. So how fast that beat to beat variation can occur is a term called heart rate variability.
So just to clarify, even when your heart rate is regular, every beat is not equally spaced. There is always that variation.
Now that variation is in milliseconds. We talk about 1,000s and thousands of a second, right? But for each heartbeat that matters. And there is mathematic tools. I mean, these devices, they're called SDNN, standard deviation, and root mean squares. So all these are tools to actually figure out that variability. So Apple Watch generates a number, Whoop generates a number. Most variables are generating that number. Again, they're looking at your variation in every pulse, and that creates the heart rate variability. So coming back to the point, like any of these tools are giving you insights. It's telling, like Whoop gives you sleep data, right? I mean, we talk about, the various phases of sleep. Are we focusing on the sleep? So at least now you have a tool which tells you how good your sleep is, how deep your REM sleep versus non-REM sleep is. But the second question is, how are we going to use the data? That's even more important than just wearing a wearable.
So, I mean, in terms of sleep, I feel knowing is half the job, sleep or exercise. So Whoop gives you like calculated variables on strain and recovery. Strain is their kind of algorithmic calculation which takes into account your heart rate, your activity, your respiratory rate, your body temperature, the whole thing, how well you recover.
Correct.
So it's more for like athletic sort of performance, but your day-to-day as well. And I particularly like the idea of total strain because even when you're sitting in a busy boardroom conversation, you are under certain amount of strain. And if that's high, that still puts a toll on your body.
Correct. I agree with your point because, Apple Watch has all the data too, right? But then you have to use you have to piece them together. If, we're all busy, right? Who has time to look into all these things? So if that tool gives you, okay, today was my strainful, this is a strain day, this is not a strain day, and you can pinpoint what caused. Like for me, I don't drink alcohol, right? But every time I do, like even a glass of wine, my sleep is gone. My heart rate variability is down the drain. So to me, I mean, it's definitely helping me. Even like what tiny things I'm doing is making big changes to my health. And over time, remember, it's not one day. This is going to collectively, if I keep getting data again and again and again, hopefully I'll have enough impact on my behavior. And that's what we want for all patients, right? I mean, these are devices which are easily accessible for most patients now. So I think variables are here to stay. And then the key is, one, to know the data, and number two is, how can we tell our patients how to use the data?
Exactly. I mean, as far as accuracy is concerned, I mean, you're talking about mid to high 80s in terms of accuracy in sleep detection for Whoop,
Correct.
from what I understand. And it's good for broad sleep stages compared to the gold standard, which is the sleep study.
Right.
But from what I could find is more accurate for REM sleep. It may overestimate the deep sleep a little bit.
The Whoop, you mean?
Yes, the Whoop. But I mean, coming to that, of course, I don't think you want to use these as like the dictum, okay, I got this much today. I think this is consistency of wearing and seeing which way your data is tracking
Correct.
day to day, as opposed to an isolated
Correct.
window.
It's the trend.
Exactly.
Are you heading in the right trends, right? That's what more important is.
And I mean, the other reason I particularly like this is, of course, there is no screen, so no distraction.
Correct.
The data goes straight
and
to.
it's easy to wear. You can sleep at the night. I could not sleep with an Apple Watch. Believe me, I tried.
Well, nothing against that. We use Apple products, but I particularly like this in terms of fitness tracker. We'll talk in our future episode about the other wearables like Oura Ring and see how these two compare.
Correct.
But all in all, it was a great conversation. Thank you so much for taking the time, and hope to talk to you soon. Next time we'll talk about
Absolutely.
pacemakers.
Thank you for having me. Appreciate it.